Stevens-Johnson syndrome, SJS, and toxic epidermal necrolysis, medical emergencies that demand mastery. Ladies and gentlemen, let's delve into a topic of critical importance: Stevens-Johnson syndrome and toxic epidermal necrolysis, not merely conditions but medical emergencies where every moment counts. These severe, potentially life-threatening disorders demand your utmost attention and understanding, and here's why: early recognition and diagnosis, the difference between life and death. Imagine this: flu-like symptoms creeping in, followed by an agonizing rash that spreads, blisters, and culminates in the shedding of the skin's outermost layer. This is not just a rash, it's a cry for immediate medical intervention. Early recognition of these harrowing signs by healthcare professionals, especially those in emergency medicine and dermatology, can be the pivotal factor that saves a life. Timely diagnosis changes outcomes. Understanding the causes, knowledge is prevention. The culprit. Adverse reactions to medications. From antibiotics to anticonvulsants and NSAIDs, these drugs are often the silent triggers behind SJS and TEN. As a healthcare provider, you must know the usual suspects to mitigate risk and prevent these conditions from taking root. Patient management, the art and science of healing. Management is a balancing act. First, halt the offending medication. Then, shift focus to life-saving supportive care, often in burn units or intensive care settings. From combating infections to ensuring hydration, your actions define recovery. Understanding these strategies isn't optional, it's your duty to provide the highest standard of care. Prevention and risk assessment, the power of anticipation. Prevention is our strongest ally. Certain genetic markers, like HLA-B1502, significantly elevate risks, especially with specific drugs. Knowing a patient's risk profile empowers you to make safer, tailored choices. Risk awareness today means fewer emergencies tomorrow. Patient and family education, a pillar of trust and awareness. Empowerment through education can be transformative. By teaching patients and families about the signs, symptoms, and potential drug reactions, you create a safety net. Knowledge doesn't just foster trust, it saves lives by enabling early detection and timely intervention. Research and future therapies, expanding the horizon. Medicine evolves, and so should we. Ongoing research into the pathogenesis, risk factors, and therapeutic approaches of SJS and TEN is our path to better outcomes. Staying informed fuels your role not just as a caregiver but as a pioneer in advancing medical science. Let's take a moment to transform your knowledge of Stevens-Johnson syndrome, SJS, and toxic epidermal necrolysis, TEN, into powerful, practical applications. This isn't just about knowing, it's about making a difference in clinical practice, patient advocacy, and beyond. Clinical practice, your frontline defense, early detection, the ability to recognize the earliest signs, from flu-like symptoms to the hallmark rash, isn't just a skill, it's a life-saving capability. Catching these symptoms early means initiating prompt treatment, potentially halting the disease's progression. Patient management, effective management starts with stopping the offending medication. But it doesn't end there. Your role extends to providing critical supportive care in ICUs or burn units, addressing complications like infections and dehydration. Mastering these strategies ensures you're equipped to meet the needs of these vulnerable patients. Patient education and advocacy, a life-saving dialogue. Educate patients. Knowledge is empowerment. Informing patients about high-risk medications and teaching them to recognize early symptoms can make the difference between rapid intervention and devastating outcomes. Advocacy, become a champion for patient safety. Advocate for better protocols in handling drug allergies and adverse reactions, ensuring that healthcare systems are prepared to act decisively against these conditions. Risk management and prevention, a proactive approach, drug selection, knowledge of genetic predispositions, such as HLA-B1502, allows you to personalize drug choices. Order genetic tests for high-risk patients before prescribing medications that could trigger SJS or TEN, especially in populations with known vulnerabilities. Monitoring and follow-up, rigorous follow-up for patients on high-risk medications is essential. This isn't just good practice, it's a commitment to safeguarding their well-being. Research and development, pioneering new frontiers, contribute to research, dive into studies exploring the pathophysiology, risk factors, and treatments for SJS and TEN. Your contributions could illuminate new pathways for understanding these conditions, develop guidelines, use your expertise to refine clinical guidelines, ensuring they reflect the latest research and offer actionable insights for preventing and managing these life-threatening disorders. Interdisciplinary collaboration, the power of teamwork, collaborate across specialties. No one tackles SJS and TEN alone. Partner with dermatologists, pharmacologists, geneticists, and other specialists to craft comprehensive care plans. Collaboration enhances patient outcomes and fosters innovation in treatment approaches. Policy and healthcare system improvement, beyond the bedside, influence policy, advocate for mandatory reporting of drug-related adverse effects. Push for better monitoring systems, updated drug warnings, and accessible educational materials that equip both professionals and patients. Through real-world scenarios, let's uncover how these conditions manifest and are managed in diverse, high-stakes situations. Case 1, Early Detection and Intervention. Scenario: a 32-year-old woman arrives at the emergency department with flu-like symptoms and a rapidly spreading, painful rash. The rash appeared 2 days after starting an antibiotic for a respiratory infection, now covering 20% of her body surface area, with blistering and redness. Clinical decision: recognizing the signs of SJS, the emergency team immediately discontinues the antibiotic and transfers the patient to the burn unit. Aggressive management begins: intravenous fluids to combat dehydration and comprehensive pain relief. Outcome: thanks to early intervention, the patient's condition is stabilized, avoiding progression to the extensive skin detachment seen in TEN. With supportive care and wound management, she recovers without significant complications. Case 2, Drug-Induced SJS/TEN. Scenario: a 45-year-old man with a psychiatric disorder develops a severe skin reaction weeks after starting carbamazepine. His condition includes extensive skin necrosis and detachment, involving 30% of his body surface area and mucous membranes. Clinical decision: the diagnosis: TEN induced by carbamazepine. The offending drug is immediately stopped, and the patient is admitted to the ICU. Treatment includes immunoglobulins to suppress the immune response, aggressive infection control, and management of hydration and electrolyte imbalances. Outcome: although the initial presentation was severe, the patient stabilizes with intensive care. However, he experiences long-term sequelae, including scarring and ocular complications, requiring ongoing follow-up. Case 3, Genetic Predisposition. Scenario: a Southeast Asian patient presents with SJS symptoms 2 weeks after starting an anti-epileptic drug associated with a higher risk of SJS/TEN in individuals with the HLA-B1502 allele. Clinical decision: genetic testing confirms the HLA-B1502 allele, prompting immediate discontinuation of the drug. The patient is admitted for specialized supportive care to manage symptoms and prevent complications. Outcome: thanks to rapid diagnosis and treatment, the patient recovers with minimal complications. Moving forward, an alternative medication with a lower risk profile is prescribed, tailored to their genetic predisposition. Case 4, multi-drug therapy complication, scenario, a 56-year-old with diabetes, hypertension, and epilepsy develops SJS. The trigger remains unclear due to polypharmacy, with several potential offenders in the mix. Clinical decision: all non-essential medications are stopped. The medical team conducts a systematic review of the patient's drug regimen, identifying high-risk medications and prioritizing safer alternatives. The patient receives specialized supportive care to stabilize their condition. Outcome: this careful approach prevents further aggravation and allows recovery. Re-challenge with essential medications is conducted under strict supervision, pinpointing the specific trigger to prevent future reactions. Let's explore how the initial assessment sets the stage for life-saving care. 1. Patient history. The clues are in the details. Medication history. Start with the basics. What has the patient been taking? Antibiotics, anticonvulsants, and NSAIDs are often the culprits. Your goal: identify and isolate potential triggers. Symptom onset. Create a timeline. When did the rash appear? How does it align with the initiation or change of medications? Past medical history. Uncover any history of drug allergies, previous skin reactions, or relevant family history. Recent infections. Ask about recent illnesses, which can sometimes mimic or contribute to SJS/10. 2. Physical examination. Decoding the visual evidence. Skin examination. Look for purplish or red spots coalescing into blisters. Check for Nikolsky's sign, gentle pressure causing the skin to slough off, a hallmark of epidermal detachment. Mucosal involvement. Examine the eyes, mouth, nose, and genital areas for blistering or ulcers, common indicators of SJS/10. Extent of involvement. Use the body surface area, BSA, to differentiate severity. SJS, 30% BSA. 3. Vital signs monitoring. Gauging stability. Assess stability. Check temperature, blood pressure, heart rate, and respiratory rate to detect any immediate threats. Signs of systemic involvement. Be vigilant for shock, tachycardia, hypotension, or altered mental status, which may signal life-threatening complications. 4. Laboratory tests. Gathering the proof. Routine blood work, a CBC, electrolyte panel, and renal/liver function tests help assess overall health and detect organ dysfunction. Skin biopsy. If the diagnosis is uncertain, a biopsy revealing full-thickness epidermal necrosis confirms SJS/10. Infection markers. Use cultures or PCR testing to rule out infectious causes. Mucosal assessment. The hidden danger zones, mucous membranes. Examine the oral cavity, eyes, nasal passages, genital area, and anus. Look for signs of blistering, erosion, ulceration, or sloughing. Severity of mucosal involvement. Document the extent of damage, as mucosal complications are predictors of severity and may lead to secondary infections or scarring. Ophthalmological examination. Protecting vision, eye involvement. A meticulous eye exam is mandatory. Look for conjunctivitis, corneal ulcers, or panophthalmitis, which can progress to blindness if untreated. Visual acuity. Conduct basic visual tests to detect immediate impairment, as early intervention is crucial. Systemic signs. Clues to severity. General symptoms. Be alert for fever, malaise, and anorexia, which point to systemic involvement. Vital signs. Check for signs of systemic shock, hypotension, tachycardia, and rapid breathing, which indicate severe fluid loss or organ involvement. Assessment for complications. The broader picture, secondary infections, skin and mucosal disruption makes the patient vulnerable to bacterial, viral, or fungal infections. complicating the clinical course. Organ involvement. Look for signs of renal, hepatic, or pulmonary dysfunction, which increase morbidity and mortality in SJS/10 cases. Documentation and imaging. The power of record keeping. Photographic documentation. Take clear, systematic photographs of affected areas to monitor disease progression or regression. Chest X-ray or CT scan. If respiratory symptoms are present, imaging helps assess for pulmonary complications or infections. Interdisciplinary consultations. Teamwork saves lives. Dermatology consult. Confirm the diagnosis and guide dermatological care. Ophthalmology consult. Manage eye involvement to prevent long-term complications. Infectious disease specialist. Address or prevent secondary infections. Emergency action plan for suspected Stevens-Johnson syndrome and toxic epidermal necrolysis. Every second counts. Imagine a medical crisis where the skin itself becomes a battlefield. Stevens-Johnson syndrome and toxic epidermal necrolysis demand your immediate and decisive response. In these cases, your actions can mean the difference between life and death. Let's break down the critical initial steps to tackle this life-threatening emergency. 1. Discontinue suspected medications. Stop the offender in its tracks. Identify and stop offending drugs. The first and most critical action is to immediately discontinue any new medications started in the last few weeks. Prioritize known high-risk drugs like anticonvulsants, sulfonamides, antibiotics, and NSAIDs. Stop all non-essential medications. Err on the side of caution. Removing unnecessary drugs can prevent further adverse reactions and stop the progression of the condition. 2. Medical stabilization. Restoring balance. Fluid resuscitation. Combat dehydration caused by extensive skin loss and maintain blood pressure. Initiate fluid replacement therapy promptly, tailored to the patient's needs. Temperature regulation. Address impaired thermoregulation due to damaged skin. Use warming blankets or temperature-controlled environments to stabilize body temperature. Pain management. Administer analgesics to alleviate the severe pain associated with SJS/10. Options include acetaminophen, opioids, or NSAIDs, based on the patient's medical history and condition. 3. Urgent referral to specialized care. The right setting saves lives. Admission to appropriate unit. For extensive skin involvement or severe systemic symptoms, transfer the patient to a burn unit for advanced wound management, an intensive care unit, ICU, for critical systemic support. These specialized units are equipped for complex care needs, including wound care and critical monitoring. 4. Fluid and electrolyte management. Replenishing the body. Hydration. Aggressive fluid resuscitation combats fluid loss from denuded skin and fever. Meticulous monitoring ensures hemodynamic stability, using metrics like urine output, vital signs, and blood tests. Electrolyte replenishment. Frequent corrections of sodium, potassium, and magnesium are essential to address imbalances from fluid shifts and losses. 5. Pain management. Alleviating suffering. Analgesia. Administer pain relief based on severity. Opioid analgesics for severe pain. Non-opioid options like acetaminophen for mild to moderate pain. Topical anesthetics for mucosal lesions. Comfort measures. Use soft bedding, minimal handling, and temperature-controlled environments to reduce discomfort. 6. Wound care. Healing the skin. Skin care. Apply non-adherent dressings to protect wounds and support healing. Use silver sulfadiazine cream selectively to prevent infection in exposed areas. Infection prevention. Proactively assess for infection signs. Reserve antibiotics for confirmed secondary infections. 7. Mucosal care. Protecting vulnerable areas. Oral care. Maintain oral health and comfort with regular saline or antiseptic rinses. Ocular care. Consult an ophthalmologist for eye involvement. Use lubricating eye drops or ointments to prevent corneal damage and dryness. Pharmacologic treatments. Building a pain relief arsenal. Opioid analgesics. Necessary for severe pain. Opioids provide systemic relief but require careful monitoring to avoid side effects like respiratory depression or constipation. Example: morphine 2 to 10 mg for every 4 hours as needed, adjusted for response and renal function. Non-opioid analgesics, effective for mild to moderate pain. Options like acetaminophen or NSAIDs should be used cautiously, particularly in dehydrated patients at risk for renal complications. Example: acetaminophen 500 to 1000 mg orally every 6 hours as needed. Topical anesthetics provide targeted relief for mucosal lesions. Example: lidocaine 2% gel applied to affected areas up to every 4 hours as needed. Adjuvant pain medications, enhancing relief. Anticonvulsants, medications like gabapentin or pregabalin address neuropathic pain, particularly persistent burning sensations. Example: gabapentin 300 mg orally 3 times a day, titrate as needed. Antidepressants, tricyclic antidepressants such as amitriptyline can alleviate neuropathic pain while also improving mood. Example: amitriptyline 25 mg orally at bedtime, monitor for anticholinergic effects. Antibiotic stewardship, using antibiotics wisely. Prophylactic antibiotics, avoid routine use unless clinically indicated to prevent antibiotic resistance. Use only for confirmed or strongly suspected infections, guided by clinical judgment. Targeted therapy, initiate antibiotics based on culture and sensitivity results. Start with empirical therapy if infection is suspected, tailoring it based on local antibiogram data. Immunomodulatory therapy in SJS and 10, promising innovation or controversial gamble, in the battle against Stevens-Johnson syndrome, SJS, and toxic epidermal necrolysis, 10, two of the most devastating dermatologic emergencies. Immunomodulatory therapies present a tantalizing yet controversial option. By targeting the immune-driven destruction of skin and mucosal tissues, these therapies hold potential, but their use is fraught with debate. Let's explore the therapies, rationale, controversies, and future directions in this critical area of treatment. 1. Types of immunomodulatory therapies. Tools in the arsenal. Intravenous immunoglobulin, IVIG, blocks phosphos-ligand interactions. A key pathway in keratinocyte apoptosis, proposed to halt skin detachment and reduce disease progression. Corticosteroids, their potent anti-inflammatory effects may suppress the acute immune response in SJS/10, historically used, but with mixed results and significant side effects. Cyclosporin inhibits T-cell activation and interleukin release, potentially controlling the immune-mediated epidermal necrosis. TNF-alpha inhibitors target TNF-alpha, a cytokine central to the inflammatory cascade, to reduce severe inflammatory responses. Current recommendations. Cautious optimism. Guidelines. Most recommend immunomodulatory therapies only within clinical trials or for severe, refractory cases. Clinical judgment. Decisions should consider individual patient factors, severity of disease, response to supportive care. Systemic steroids in SJS and 10, a double-edged sword in the fight for survival. The use of systemic steroids in managing Stevens-Johnson syndrome, SJS, and toxic epidermal necrolysis, 10, is one of the most hotly debated topics in dermatology in critical care. On one hand, steroids hold promise as potent anti-inflammatory agents. On the other, they carry significant risks that could worsen outcomes. Rationale for using systemic steroids. Theoretical mechanism. Steroids like prednisone or prednisolone suppress the immune system's overreaction, aiming to halt the progression of skin and mucosal damage, reduce the severity of the inflammatory cascade. Arguments for using steroids. Early intervention. advocates believe initiating steroids early in the disease course could prevent extensive epidermal detachment, inflammatory control. By dampening the immune system's response, steroids might reduce symptoms like redness, swelling, and pain, improve patient comfort during the acute phase. Arguments against using steroids: risk of infection. Steroids suppress the immune system, increasing vulnerability to secondary infections, a leading cause of mortality in SJS/10. Delayed healing. Concerns about impaired wound healing may deter their use, given the extensive skin damage in these patients. Lack of conclusive evidence. Research outcomes are mixed. Some studies show no significant benefit in reducing mortality or morbidity. Retrospective data even suggests higher mortality rates with steroid use. Fluid retention. Steroids can cause fluid retention, complicating the already delicate fluid balance in patients with significant skin loss. Clinical evidence and guidelines. Mixed research findings. Evidence from studies is conflicting. Early use shows potential benefits in limited studies. Other data warns of increased risks and no clear mortality reduction. Guidelines. Most clinical guidelines advocate caution, limit use to clinical trials or severe cases. The journey through Stevens-Johnson syndrome, SJS, and toxic epidermal necrolysis, 10, is one of immense challenge, marked by pain, uncertainty, and resilience. However, the role of education in this journey cannot be overstated. It transforms patients and families from passive recipients of care into active participants in the healing process. By fostering understanding of these conditions, recognizing early signs, and implementing prevention strategies, we equip patients and caregivers with the tools to navigate recovery and prevent future episodes. Through psychological support, long-term management plans, and empowering knowledge, we not only address the physical wounds but also help mend the emotional and psychological scars left by these life-altering conditions. This collaborative effort, between healthcare providers, patients, and families, creates a foundation for hope, resilience, and a renewed quality of life. With education as our guiding light, we can help survivors of SJS and 10 reclaim their lives, moving beyond survival to truly thrive. In the end, it is the strength of informed minds and supported hearts that turns adversity into empowerment. Thank you.